So, first I'd like to start by paying my respects to the Wurundjeri people of the Kulin Nation, the traditional custodians of the land where we meet today, and also to the Wathaurong people with whom I have the pleasure to work alongside. I would like to pay my respects also to elders both past, present and future, and any community elders in the room today. So for those of you that are not from Victoria, this is where the Ballarat and District Aboriginal Cooperative is. So you've got obviously you know you're in Victoria because you're all here, but we're about 120 kilometres out. And this project has been funded by the Department of Human Services, and Baddak has been identified as the first site. The partnership steering group includes Professor Kerry Arabina, departmental representatives, Associate Professor Marion Saville, Bernadette Souter from Cohurst and Paul Burke. So the aim of the pilot has been to increase cervical cancer screening in under-screened populations, and that's by developing an acceptable and high-quality model to implement HPV self-collection. And I must say, since being involved in the pilot, there's been an enormous amount of interest, and I think it's going to be a very acceptable way for many women who've struggled with the routine Pap test. So as you can see, the objectives were to be able to recommend a pathway that would be able to be used in the Renewal, which is the change of the National Cervical Screening Program, which will happen next year, and to develop a clinical practice approach, all the nuts and bolts to support people undertaking this with the new pathway in Renewal. And that includes workforce resources and preparing the workforce for how to manage this in the clinical setting. Now, I'm just going to do a little bit of a touch base about some of the challenges Indigenous community experience. They're 2.8 times more likely to develop invasive cervical cancer and 3.9 times more likely to die of cervical cancer. Now, we know the Pap test is a fantastic preventative tool, can prevent up to 90%, but sadly Indigenous community are more likely to be diagnosed later and have more advanced disease as a result. In Victoria, 50% of women diagnosed with invasive or micro-invasive cervical cancer have no known screening history, and 28% have not been screened in the last 2.5 period in detection. So I think it's clear that we have a challenge for Indigenous people, and this is why this particular pilot started out at an Indigenous service. So the self-collection would be undertaken by a medical or current nurse cervical screening provider who currently works in that field, and it's facilitated at a medical service. So the pilot will be for both vaccinated and unvaccinated women in the 27 to 74 age group. Some of the barriers that I think we recognise for Indigenous community, some are societal, which are largely structural and practical, and some are emotional, psychological barriers to participation due to personal experience, trauma and history. And I think it's in this situation that we realise that the barriers are more acute for Indigenous Australians owing to their disenfranchisement and their well-documented social disadvantage. So phase one was, as I said, decided to be run from the Barlinjan Clinic, and it's one of the Aboriginal community-controlled health organisations that's been in operation since '79. And our clinic takes a very holistic approach. I think we're extremely lucky in that way, that our aim is to take the time to be really holistic. And whilst it may not seem a high number, but to have well over 900 Indigenous community attending is a really sizable community clinic. So that's us there. So one of the reasons why we became involved in this pilot was because we've been undertaking quite considerable work with the community since we've had the before we've had the nurse-led clinic, and since, in increasing the screening of women. And as you can see from this graph, which portrays the changes from 2010 to 2015, we had greater than 50% of our community with no known Pap test history in 2010. And so it's been a combination of systems design working with things like PenCat to actually identify the non-known histories, and to work in ways in our systematic work with permission slips and registrations to increase that number. And so where are we now? Well, we're certainly up there with the number of women screened. And if I move to the next slide, it's a bit fat, isn't it? It's not quite round. But anyway, the percentages work quite well. So you can see that in a 2 to 3 year period, there's a very high percentage of women screened. And interestingly, in the greater than 3, 4 to 5 and greater than 5, those are shrinking because the trial is undertaken for women who are at least 1 year overdue in that age group. So it's lovely to see some of those numbers going down. What are the challenges that have been identified in the phase one of the trial? Well, I think building an ATSI workforce is always a challenge. And we identified in working, and we're fortunate that we do have an Indigenous nurse cervical screening provider at BADAC, so there is a lot of, as well as quite a few female GPs, so we've spoilt for choice. We all know that recalls have limitations in engaging clients that haven't moved into the system or who are transitory. Not everyone has the time and the ability to work with PenCat to do that sort of work, time being probably one of the highest challenges. And for our clinic, it's the mobility of the clients. Our clinic numbers are constantly increasing. So as I said, we've developed some very simple permission forms that are part of registration processes. We even have the permission to access screening history in the enrolment of babies to the clinic, because we've had 86 babies in the last year, and that gives us the opportunity to then follow up with the mothers about their screening. I did have one dad give the permission for his partner to have their screening checked. We had to take a different route with that one. So how did we engage the community? Well, we had a fantastic launch with Pap Screen's amazing Tammy Anderson. I wish she was a relative, but she's the comedian and I'm the health person. And she did this marvellous performance called The Great Walls of Vagina. And it's through the wonderful voice of comedy, engaged with the community at the launch and explored the challenges around Pap tests and how self-sampling would be a good solution. And you can see me there with the speculum and Tammy with the swab, which was much more preferable. Of course, elders were a key part of it, and community leaders supporting what we were doing meant that there was a greater engagement in the community. Now, I'm not going to go into a lot of detail about the screening pathway, but for those of you that are working in the clinical coalface, you would know that engaging women around cervical screening, it's probably never one conversation. And for those that are under-screened, it's more than one. And so a lot of the women that aren't screened in our service, we know why, and there has been many conversations about how could we get around some of these barriers. So if a woman is offered a traditional test and refused, and she's eligible, then she can be offered the self-sample. Here again is another flow chart that just shows at that point when she accepts the sample, a certain percentage of the women will be interviewed to get their qualitative feedback. Qualitative feedback, sorry, I'm tripping over words. So our population at BADAC that are under-screened is really small, and a lot of that's because the age group of women, unfortunately, as they get older, greatly diminishes as a population. So our numbers have grown a little bit since this report was put together. Currently, we've had 16 women out of 20 who've participated, and from those women, we've had the test looks for no HPV, HPV other high risk type, or HPV 16 and 18. Of course, which you'd be familiar because 16 and 18 is in the vaccine, along with 6 and 11. So, and there is different follow-through for those women. So if they have an other high-risk type, then it's a traditional cytology test using the liquid-based cytology. The women who have been in that position have all very comfortably accepted coming back in, and we have managed to get through that because clearly they weren't embracing that approach to start with. But having the information that there were some changes there, some risky HPV identified, they were happy to go ahead. Now the next phases will be, and have started at Co-Health and Access Health, and that's just a little slide that shows the percentage of acceptability rate, which is really high at 77%. So women were surveyed with their permission after immediately participating in self-sampling, and if they refused self-sampling, they were also offered an interview. We wanted to understand why. And some women refused self-sampling but decided to then go on and have a traditional Pap test because obviously some of the visual inspection was of value, and they realised that when they saw both options. And then there was a second survey that was undertaken after the results were finalised. Staff were surveyed and some family members were surveyed, mainly to understand how the family felt about women who weren't up to date with their screening. Key findings. They were really interesting, and I'm sure you're sharing slides from this, aren't you? Making them available to participants? Yes. Yeah, because I'm going to pick out some highlights. I'm not going to read through this. So, distrust of the health system, words like it was frightening. It was so very, very uncomfortable. It was awful. I didn't want to go back. I don't think I'd had one done till we moved down, or 6 or 7 years. It was really scary. And distrust of the health system. These were the themes that came out. Never again, you're not touching me down there, no more. To put one of them in is the most humiliating thing that could have happened to me, other than being taken from my family, and I think that's mind-blowingly strong. But now you've got me after the self-sample. I'm willing to do it every 5 years. That's easy. And talking about unprofessional service, where discrimination and racism have an impact, and women not feeling of the same, feeling inferior in their engagement with the health system. Surprisingly, the discomfort and hurt were quite high, but it seemed to be that a lot of the hurt was psychological from past experiences. Certainly saying that it's uncomfortable, but I worry about the results and I worry about the unknown. Talking about the self-sampling, it's more comfortable to do it yourself, it's less invasive. Normal pap tests are painful for me, so this test is better. Embarrassment and shame, that's, I think, quite understandable, and certainly in overcoming emotional barriers, knowing I could do it in the comfort of myself, and then if I needed, there was a backup of a trusted professional. To be honest, I've had low-grade changes before and I've been afraid. The test before had hurt me. So other findings that we found were around cost. Women reported money was a prevention from accessing services. Poor public transport. Half of the women that took the self-sample had key responsibility for their children or grandchildren, which is quite common in the community. 2 of them had noted that recent improvements in looking after their health was a motivation. Convenience and ease. I could do the self-sample every week and I'd be fine with that. Such a contrast. And the closeness of the community also makes it clear in women's enthusiasm to tell women and families and spread the word. And isn't that always the way? It's the word of mouth that moves around so well. So also, before I get to the conclusion, disenchantment with the medical system, and women finding, for one particular woman, she struggled with the gender of the provider, and just said she felt that the last male that had undertaken a pap test had been particularly rough. So in conclusion, a unanimous preference for self-sampling over the regular pap test. We certainly require the right resources, and we've been fortunate for this trial to have pap screens expert support in developing those. Certainly there might be financial, transport, reminders, childcare, all manner of other areas that need to be engaged through the follow-ups. And the understanding that Indigenous women require empathetic, culturally in tune services. As I've said before, the community is very important and an asset in promoting acceptability. For women who've been reluctant to have a PAP in the past, this is an acceptable and viable option. Thank you.